Good morning, everybody. I thank my professor and head, Kamal Madam, to give me this opportunity for the speaking in a e-learning program. I will be dealing with the mainly histopathology pertaining to the psoriasiform dermatosis. Dr. Bhatt has nicely explained the general approach, whereas I will be restricting myself to the specifically the psoriasiform dermatosis histopathology. The psoriasiform dermatosis often poses challenge to both dermatologists and pathologists alike. With proper clinico-pathological correlation and a systematic approach, it is possible to arrive to a specific diagnosis in most cases. The psoriasiform dermatosis comprises of wide variety of diseases that resembles each other both at clinical as well as the histologic levels. The correct diagnosis is reached with good clinico-pathologic correlation. The psoriasiform dermatosis includes wide variety of diseases, some of which show both clinical and histological overlap. However, it is possible to give a specific diagnosis in most cases with logical and systematic approach. यहाँ पे लगाओ. Hello. The psoriasiform reaction patterns. As Bhatt Madam has said, the morphologically the presence of epidermal hyperplasia with elongation of rete ridges. Whenever we came across such a type of findings in skin biopsy, we label it as a psoriasiform lesion. The psoriasis literally means a itchy condition. This is derived from a Greek word. The psoriasiform dermatosis can be broadly classified as psoriasiform only, even or uneven psoriasiform hyperplasia. Then combination like psoriasiform plus lichenoid, psoriasiform plus spongiotic, psoriatic plus spongiotic and lichenoid, this combination is most of the time seen. Further, based on the dominant inflammatory cells infiltrate, that is lymphocytes only, or admixture with other cells such as eosinophils, histiocytes or the plasma cells, this psoriasiform dermatosis can be classified into different types of dermatosis. This coupled with a detailed stepwise analysis of findings beginning right from the top of the stratum corneum help us to arrive at a right diagnosis in psoriasiform dermatosis. The microscopically first thing is to note is the epithelial hyperplasia with elongation of the rete ridges. The histopathological criteria based on which we can analyze our biopsy is the psoriasiform epidermal hyperplasia with regular elongation of rete ridges, parakeratosis, orthokeratosis, Munro's and Cogos microabscesses, suprapapillary thinning, then inflammatory infiltrate, widened rete ridges, prominence or absence of the granular layer, and capillary proliferation in the papillary dermis. The first thing is the psoriasiform epidermal hyperplasia with elongation of the rete ridges. Apart from epidermal hyperplasia and elongation of rete ridges, other findings in epidermis is diminished or absent granular layer seen in classic psoriasis. In psoriasiform dermatitis, or in which is the psoriasis is the prototype of this psoriasiform dermatosis, there is either absence or the granular layer can be seen, reduced granular layer. The clinically atypical or treated unresponsive lesions, granular layer may be normal or thickened as in other diseases like pityriasis rosea, like in simplex chronicus. Then too much stress should not be placed on this condition. The second thing to be noted in the epidermis is the pallor of the keratinocytes. The presence of neutrophils in between the keratinocytes with early spongiosis indicates the psoriasis. The neutrophils in between the keratinocytes with spongiosis is also known as the Cogot's abscess, which is a hallmark of the psoriasis. After ruling out the possibility of the dermatophytes in the epidermis, this requires the special stain to rule out because these abscesses may be secondary to the fungal infection. Then the parakeratosis. The normal basket weave pattern is lost in most of the psoriasiform dermatosis. Commonly, the parakeratosis is seen is the confluent parakeratosis, that is the continuous type of the parakeratosis. The parakeratosis means the presence of nucleus in the keratin layer. Now, this presence of nucleus indicates the rapid proliferation of the keratinocytes, which is one of the pathophysiology of the psoriasis. In the psoriasis, there is a rapid proliferation. It takes only 2 to 3 days instead of 4 weeks to proliferate the keratinocytes in the psoriasiform dermatosis, which is similar to the nucleated RBCs in the peripheral smear, which indicates the proliferation of the bone marrow. The presence of normal basket weave pattern above is indicate the recent onset. Means association of the parakeratosis along with the orthokeratosis, which is in the top of the parakeratosis. This indicates the early lesions. When parakeratosis with neutrophil is seen beneath the basket weave cornified layer, one has to look carefully for the fungal hyphae. This is known as the sandwich sign, where you get the basket weave keratin, that is the normal keratin layer, then neutrophils, and then the parakeratotic layer. Whenever you observe such a type of arrangement, that is the sandwich sign, you must lower your condenser and see for the fungal hyphae or go for the spacious stain. The suprapapillary thinning of the epidermal plate pointer. the suprapapillary plate is thinned out, and you can note the papillary dermis, the dilated blood vessels with tortuous blood vessel can be seen. Now this leads to a special sign which is known as the Auspitz sign in the psoriasis, where when you remove the scale, you can see the pinpoint hemorrhagic spots below the scale. The psoriasis is characterized by the suprapapillary thinning. Elongated dermal papillae contain the dilated and tortuous capillaries, and these particular dilated capillaries in the papillary dermis leads to the secretions of plasma as well as the exostosis of the polymorphs in the keratin layer of the dermis, which is one of the pathophysiology of the psoriasis. This particular plasma takes the various the mediators of the inflammation, which leads to the rapid proliferation and the various types of the immunoglobulins can be deposited there. And this is one of the theory for the psoriatic form dermatosis or the psoriasis, where you get the immunological cause for the Munro's microabscess and Cogos abscess. The most of the psoriasiform dermatosis dominated by the lymphocytes in the dermis, specifically in the dermis. But the spongiform pustules of Cogos and the Munro's microabscess, which shows this is the Munro's abscess which is seen in the keratin layer, whereas this is the spongiform pustule of the Cogos which is seen in the epidermis. The Cogos and the Munro's abscess are truly diagnostic of the psoriasis, and in their absence, the diagnosis can rarely be made with a certainty on histologic basis. These two are important. If they are present, then we can diagnose 100% as a psoriasis in the psoriasiform dermatosis. There are various types of the conditions which are grouped under major psoriasiform dermatosis. These are psoriasis, which is a prototype of this group, then psoriasiform keratosis, pustular psoriasis, Rhetus syndrome, Pityriasis rubra pilaris, parapsoriasis, lichen simplex chronicus, and the prurigo nodularis, which has got the different histology in the somehow, but they have got the epidermal hyperplasia, which group this condition in a psoriasiform dermatosis. The other conditions like acute, the subacute and chronic spongitic dermatitis, erythroderma, mycosis fungoides, chronic candidiasis, inflammatory linear varicose epidermal nevus, Norwegian scabies, Bowen's disease, clear cell acanthathoma, all these conditions can mimic either clinically or histologically the psoriasiform dermatosis. Now the mycosis fungoides, the Bowen's disease is entirely different conditions, but they have got the psoriasiform hyperplasia in the epidermis. The prototype of this particular psoriasiform dermatosis is the psoriasis. In short, about the clinical presentation, This psoriasis has got the several clinical variants of psoriasis have been recognized. They may be the gutted psoriasis, erythrodermic psoriasis, sebo-psoriasis, photosensitive, or inverse psoriasis, which is known as the flexural psoriasis. This is the clinical presentation. The clinical photograph shows the scaly lesions in the extensor surface or in the joints. The psoriasis have got the various, the exacerbation and the remission. The trauma, infection, drugs, climates or stress may lead to the exacerbation of the lesion. The pathophysiology of the psoriasis, in short, we can say it is a immunologically based disorder in genetically predetermined person controlled by the various environmental conditions. This is in short. It is immunological. There are some genetic involvement is there, and the dry weather, cold weather, which lead to the exacerbation of this particular condition. Then we'll see the histological appearances of the different Psoriasiform dermatosis. The chronic plaque psoriasis is the classic form of the psoriasis, where you get the Munro's microabscesses. So here, as the approach of the diagnosis of any skin lesion, you should go from the scanner view to the high power and then the more high power views. The scanner view will give the appearance of the regular acanthosis. Then high power view will give the collection of the polymorphs in the keratin layer, forming the microabscesses in the keratin layer, which is a hallmark in the diagnosis of the psoriasis. Then hypogranulosis. Now this hypogranulosis is important and it corresponds with the parakeratosis in the keratinous layer. Then suprapapillary plate thinning. The suprapapillary plate thinning leading to the classic sign, Osgood sign in the classical psoriasis, and the various exostosis of the polymorphs and the serum can be collected at the suprapapillary region. The second is the gutted psoriasis. Now this gutted psoriasis is the special form of psoriasis seen in children, often occurs after the illness, that is the post-streptococcal pharyngitis, and the lesion is seen over the trunk. Here specifically the focal mounts of parakeratosis. There is no confluent parakeratosis as seen in the classical type of psoriasis. There is less acanthosis than the psoriasis because it has got the rapid course. It is post-streptococcal and it has got the rapid course. The acanthosis or the thickness of the epidermis will be less as compared to the classical psoriasis. The overlying orthokeratosis of normal basket view type can be seen intermittent with the parakeratosis. The focal loss, because the parakeratosis is focal, that's why the granular layer is also, there is a focal loss of the granular layer. The AIDS-associated psoriasiform dermatitis, the features of the immunodeficiency, and here in this particular psoriasis we must look for the fungus and the parasitic infestations. The Reiter's syndrome. The acute form of psoriasis from dermatosis. It's widespread eruptions of the sterile pustules associated with the, this is pustular psoriasis. It is acute form where the intraepithelial pustules are seen. They are very rapidly spreading, and this sterile pustule associated with the constitutional symptoms, and there is no eosinophils seen. If you see the eosinophils, then it will be diagnosed in other conditions. The neutrophils migrate from dilated vessels in the papillary dermis into the epidermis and aggregates beneath the stratum corneum, and the spongiform pustules of cogots is very widespread. Then the Reiter's syndrome. This is the triad of non-gonococcal urethritis, ocular inflammation, and the arthritis. The psoriasiform epidermal hyperplasia will be there. The horny layer, thick horny layer can be seen with spongiform pustulation with exocytosis of the neutrophils. Mild leukocytoclastic vasculitis is here, and partially detached horny layer can be seen. The other conditions like pityriasis rubra pilaris, here also there is combination of psoriasiform, seborrheic dermatitis, and keratosis pilaris like lesions. The psoriasiform epidermal hyperplasia alternating orthokeratosis and the parakeratosis. Short and broad acanthosis. Here you will not see the elongation of retiridges, but there is a fusion of retiridges and they are short. And hypergranulosis here. Granulosis layer is more pronounced. The parakeratosis, these conditions is the group of 2 or 3 dermatosis where we can get the psoriasiform epidermal hyperplasia, although poikilodermis lesions and epidermis is thin with loss of retiridge patterns, basal vacuolar changes, epidermostrophism of the lymphocytes is seen. The other conditions like lichen simplex chronicus, the psoriasiform epidermal hyperplasia is irregular. The prominent granular layer with patchy parakeratosis, thick suprapapillary epidermal plate, thick collagen in the vertical streak. So this is very important because you can see the collagen which has got the oriented in a vertical streak. Variable inflammatory infiltrate and the plump fibroblast is seen in this particular condition. The prurigo nodularis, again the psoriasiform epidermal hyperplasia, prominent granular layer with patchy parakeratosis, thick suprapapillary epidermal plate, thick collagen in vertical streak in papillary dermis, and variable inflammatory infiltrate and the plump fibroblast can be seen. The subacute and the chronic spongiotic dermatitis is grouped in this group of psoriasiform dermatosis because there is a hyperplasia of the epidermis. Moderate and variable hyperkeratosis is there and mild spongiosis. The spongiosis is not the feature of the psoriasis, but because of the epidermal hyperplasia, this chronic spongiotic dermatitis and the subacute spongitic dermatitis is grouped in this particular psoriasiform dermatitis. Here you can get the prominent granular layer. Erythroderma, the findings are variable and often non-specific, and mild spongiosis will be seen. Psoriasis rosea, where superficial and deep infiltrate with psoriasiform appearance, focal parakeratosis, cell spongiosis, and exocytosis of the lymphocytes in the epidermis. Psoriasis lichenoid chronica, where moderately dense inflammatory infiltrate obscuring the dermoepidermal interface. The obscuring the dermoepidermal interface is mainly the features in the lichenoid type of the lesions. Whereas the epidermal hyperplasia is grouped, because of the epidermal hyperplasia, this condition is grouped here. Then inflammatory linear varicose epidermal nevus. Here, this is the hamartomatous condition seen in the young patients. The papillated psoriasiform hyperplasia with foci of parakeratosis is seen. There is overlying hypogranulosis, alternating orthokeratosis and parakeratosis in the horizontal direction, and this gives the wart-like appearance. So all this condition, there is one study carried out in our department where we have the 400 cases of the psoriasiform dermatosis, and out of these 311 cases, where 89 cases were discarded because of the inadequate biopsy, and mainly the psoriasis is the most common condition, followed by the subacute and the chronic spongitic dermatitis, and then the other conditions has got the less importance. The thing important thing to remember is whenever you get the skin biopsy, use a stepwise logical approach. That is, from top to bottom, you must examine the biopsy. Start with the scanning magnification for the distribution of the infiltrate and uneven or even psoriasiform hyperplasia. The purely psoriasiform or combination of epidermal patterns can be noted. Spend time in examining the stratum corneum, especially to elicit the certain changes like collection of the polymorphs or other cells or some fungal bodies. Observe the changes in the rest of the epidermis, particularly the follicular infundibula, because certain conditions they are ruled out if there is a infundibular plugging. Determine the nature of the inflammatory cells infiltrate and its depth. Pay attention to the changes in the dermal vasculature. Dermal vasculature, there is dilated the capillaries in the papillary dermis, which gives the clues for the psoriasis. The earliest sign of psoriasis is the increased vascularity in the papillary dermis. That is the earliest sign. Don't forget that mycosis fungoids and the drug can mimic any of this pattern of the psoriasiform dermatosis. Be aware of the temporal evolution of the lesion. In which stage of the evolution of the lesion you are getting the biopsy. Never sign out the psoriasiform dermatosis without employing the fungal stain. Because whenever you get the collection of the microabscesses, the fungus cannot be ruled out. That's why whenever you get the Munro's abscess or the Cogos abscess, you must go for the spatial stain for the fungus. Look at the clinical findings after you have made the preliminary impression. The first, keep the slides under microscope, observe, note down your observation, and then go for the clinical details. And note the site of biopsy. This is the simplest tool for the clinicopathologic correlation. If one is unable to arrive at a specific diagnosis, despite all this, give the descriptive reports using language understood by the dermatologist. This should include the epidermal pattern and nature of the infiltrate at least. Remember that the term acute, subacute, and chronic are the clinical terminology. Their use in histopathology reports do not reflect any specificity. For example, the psoriasiform spongitic pattern with lymphocyte is the far better description than writing down the chronic dermatitis. To the clinician who has access to the complete history and the clinical findings, this implies the allergic contact dermatitis and will proceed accordingly. Do not write down the terminology like chronic dermatitis. When in doubt, ask. The incomplete requisition form are the major problem faced by pathologists worldwide, and the important to pick up the phone and obtain the missing piece of information will solve the puzzle. Thank you very much.